It's going to be very interesting. I hope you will interact and discuss as well. And it's a pleasure to introduce my co-chair, Maria, first, of course, and also the first speaker, Chiara Robba, who is the next chair of the Neurointensive Care section of the European Society and an expert in TCD and ultrasound. And this is the topic that she will discuss here for us.
Here I am. Good afternoon and welcome to this session. I'm going to give you a couple of hints on how to use brain ultrasonography in severe traumatic brain injury. A few years ago, we have published an interesting review on intensive care medicine, and I recommend it all the time just because it has something like 27 supplementary materials. So there you can really find all the methodology, all the clinical and practical part, a lot of videos which will be quite informative. So the difference between the brain and any other organs when you talk about ultrasound is that there is the skull. And so, because there is the skull and the ultrasound cannot go through the skull, we need to find some strategies, some windows to watch into the brain. There are basically 4 windows through which we can have a look at the cerebral anatomy and the physiology. And the main one, the most used one, is the transtemporal window, but then eventually you can use the transorbital window, submandibular window here, or the occipital window. We will go through the different applications. As I was mentioning, the most used one is the transtemporal window, so you just have to put your probe, and it's a 2 megahertz probe, so the same probe that we would use for cardiac ultrasonography. And now all the machines in the ICU, the ultrasound machine, have the setting specific for TCD, which is the TCCD, so the transcolor duplex Doppler. And you can, if you have a patient with intact bone, you can generally assess 3 different areas of the brain: the mesencephalic plane, which is here, and here you have a representation of a CT at this level. Here is the mesencephalus, which looks like a little butterfly when you look at it in using the ultrasound. If you put your probe 10 degrees cranially, you have the encephalic plane where you can assess the 3rd ventricle, and I'll show you how many interesting things you can do with this projection. And then the ventricular plane, when you can have an evaluation of the lateral ventricles. So, let's start from the anatomy. As I was mentioning you, the first important thing is to be in the right window, otherwise you don't see anything. And to make sure, to be sure that you are in the temporal window, what you have to do is to look at the landmarks. And the first landmarks that you have to evaluate is the contralateral temporal bone, just there, right there. And then in the middle of your image, when you are in the transtemporal window, you can assess another very important structure in terms of anatomy, and to assess the vascular and the anatomical structures, which is the mesencephalus, which is right there. And it really looks like a butterfly or whatever you want. It looks to me really a butterfly. And think about the neuroimaging and try to compare the image that you have. So your probe is here, is lateral. So if you want to compare it with a neuroimaging here, this is your major landmarks, okay? Then, if you put your probe just 10 degrees cranially, you might see a structure like this. So here you have your contralateral temporal bone here, so you know that you are in the right temporal window. In the middle, you see the mesencephalus. You go slightly up, and you have these 2 structures, hyperechogenic structure with inside something that is liquid. This is nothing else but the 3rd ventricle. And again, let's have a look at it compared to a CT. And here you can have an image of the structure and of the diameter of the 3rd ventricle. Now, you probably do brain ultrasonography just since the last couple of minutes when I started my presentation. But if I now show you 2 images like this, you will probably agree with me that here the 3rd ventricle is larger, and here the 3rd ventricle is smaller. In the right side is a patient with brain edema and cerebral edema, where the 3rd ventricle is a bit more smashed. First diagnosis after 5 minutes of training. Now, I'm joking, obviously. It requires a bit more than 5 minutes of training, but it's absolutely feasible. And one of the most important and interesting clinical applications that I think in TBI is quite useful is the evaluation of a hydrocephalus. And if you measure the diameter of the third ventricle, according to the literature, there is a cutoff of 5.5 millimeters, which has a very high sensitivity and specificity regarding the need of an EVD, the need of being drained, and also the need of, or the ability of being weaned from the EVD. This is a clinical example of a patient that I had in my unit. In this case, this patient had an initial neurosurgical procedure, so there was this little hole, and this means that we were quite happy in terms of ultrasonographic assessment, because as you can see here, the anatomy that we were able to assess with ultrasound is exactly like a CT. And we were actually able to follow up this patient using ultrasonography and reducing the number of CT, evaluating the presence, the diameter, and the progression of the hydrocephalus. Another thing that you can do, just assessing the third ventricle, as I showed you before, is the evaluation of a midline shift. So you know how clinically it is important to assess and follow up a patient with midline shift. Now, here, what we normally do in our practice is to assess the midline shift in the CT, and we use this formula, which is A, that is this distance, minus B, which is this distance divided per 2. Now, if you remember the image that I showed you before, you can freeze at the level of the third ventricle, and here you don't have anything else, but you don't have to do anything else, but do the same thing that you will do on the CT. So A minus B, and you divide it for 2. Is there a correlation with the CT? Yes, there is a positive correlation. Of course, as we are not statisticians, but we are researchers, we don't like these dots here. And in my opinion, the clinical message is that if you want to know whether the midline shift is 3.2, 3.8, ultrasound is not the best way, but if you want to follow up a patient and you see that there is an increase from 0 to 5 millimeter of midline shift, this should rise in your mind the suspect that something is happening. Other possibility, other application is in the evaluation of a intracranial hemorrhage. This is a patient who arrived in the emergency department and he had a TBI, and this was just a bit of blood. So, temporal window, we have learned that this is the first landmark, mesencephalus here, and this is a bit of blood. After a few hours, the patient deteriorated, and when we did the ultrasound in the brain ultrasonography in this patient, what we noticed was this structure here, which is nothing else but an epidural hematoma. There is, again, a significant correlation regarding the presence and the volume of extradural and subdural hematoma when you compare brain ultrasonography and CT, but here we have to always keep in mind the main limitation. So there are just a few parts of the brain that you can assess with brain ultrasonography because you have the bone. So in this case, in the temporal area, you might be lucky that you see it, but if you have a frontal hemorrhage, if the patient is not decompressed, you won't be able to see it. If the patient is decompressed, this is the image that you get when you do brain ultrasonography. And this is absolutely compatible with the CT of head. This is your median part of the brain. These are the scissors. These are the lateral ventricles. And here you have the tip of your external ventricular drain. And you can eventually use it not just to assess the anatomy, the hydrocephalus, but also to assess whether the EVD is correctly positioned. And this is a very interesting study where more than 100 patients were included, and they did exactly what the other authors on the previous study on midline shift did. So they compared the volume in the CT and in the ultrasound examination. And if you remember, the dots that we don't like as clinicians. Here they are basically disappeared. All the dots or the coefficient correlations of CT and ultrasound measurement are very, very close to the median line, and this means that the accuracy when you have a decompressed patient is very, very high. And it's very, very high when you assess the midline shift, when you assess the lateral ventricles, when you assess the third ventricle and the fourth ventricle. So all the intracranial structures. Then, so far, what we have done is just to look at the anatomy. But don't forget that one of the major components and things to assess in the brain is the vascular part. And you don't have to do anything very strange. You keep your landmarks, you find your contralateral temporal bone here, you find your butterfly in the middle of the image, and then you push the color Doppler. And what you see is nothing else but the Willis circus. It takes probably a bit of time to keep in mind the structures and to remember the anatomy, but if you remember, this is the anatomy of the Willis circle, and you can see directly the vessels of the Willis circle. Now, compared to the previous, I don't know if many of you used the blind TCD, this is an incredible step ahead, because in this case, of course, we have to remember the characteristics of all the vessels, but we can directly see the vessel so that we can have a lower number of mistakes. And again, we have to keep in mind what we have learned when we didn't have this kind of ultrasonographic assessment. And a few years ago, when I have started, we were able to recognize the different vessels according to the flow, according to the distance, according to the depth. But this is something that we still have to learn. But if you have a direct visualization of a vessel, you have a lower incidence of mistakes. Now, so far we have just watched the structure. Now we have to put what we see in the clinical practice. There are a huge number of methods and things that can be basic or can be more advanced, and and information that can be obtained using the brain ultrasonography. I don't have the time to go through all of these. I will pick up just some clinical application, those which are easier at the bedside. And one of those is the use of and the measurement of non-invasive intracranial pressure. So, what happens when you have an increase of intracranial pressure? You have, basically, this is the normal flow velocity in the middle cerebral artery. When you have an increase of the intracranial pressure, the shape of the flow velocity increases. So the differential velocities between the systolic and the diastolic gets increased. It becomes steep. And this is because there is a pressure into the brain, and the first component that is affected is the diastolic one. So, as a result of this, the pulsatility index, which is nothing else but the difference between systolic, diastolic divided for mean, increases. Okay, if you can look at the number, most of the ultrasound machines show directly the pulsatility index, but if you are expert, you can also just see what happens to the shape of the flow velocities. There are other methods, there are other formulas which have been proposed to assess non-invasively intracranial pressure, and the group of Brescia has just concluded a multi-center study about this using a formula which is based on the flow diastolic. And here the results were somehow disappointing regarding the positive predictive value, here in red, but were very encouraging regarding the negative predictive value. So, again, the message should be as before. If we want to know if ICP is 15 or 14, the non-invasive methods are not useful. But if you want to exclude whether the patient has or not increased ICP, you can actually use these methods. Another application is autoregulation. I think you have listened a lot of lectures. Mathieu yesterday was talking about autoregulation. And the reason why we use tools to measure autoregulation is that this is the physiological curve that we all know in healthy or hypertensive patients, but the reality of things is more similar to this slide. So each one of us has a different autoregulatory curve. each brain-injured patient has a different autoregulatory curve, and unfortunately, it also changes over time. So we need something, a tool that is able to tell me whether the pressure that I'm giving to the patient is okay for his cerebral blood flow. And there is a direct correlation between the flow velocity of the transcranial Doppler and the cerebral blood flow with this important limitation, so that the cross-sectional area of the insonated artery must be constant, but there is a direct correlation, so we can use it to assess the limits of autoregulation. And TCD is able to provide different information of autoregulation. It can test or can monitor autoregulation. Test is very simple. We have discussed yesterday the MAP challenge to assess autoregulation, and this is exactly what the TCD can do. You measure the arterial blood pressure and the flow velocity in the MCA, then you give a drug to increase the MAP, and then you go and see what happens to the flow velocity. If the flow velocity increases, it means that you are beyond the limit of autoregulation. Otherwise, it means that you are in a state where the patient is autoregulating properly. And the other way is the monitoring, and here comes all the group of methodologies to assess autoregulation based on software. The ESICM Plus that was discussed by Mathieu yesterday as well, but basically instead of doing something, instead of doing a MAP challenge, here you just observe the patient, you don't do anything. It's probably more physiologic but has other limitation, and the correlation coefficient between the changes of arterial blood pressure and flow velocity is able to provide a point-by-point correlation coefficient that we called MX, and that has at the end the shape of individualized autoregulatory curve of each patient. Now, just a bit of view for the future. We all know that eFast is becoming part of our clinical practice in the emergency department. The only thing missing in the eFast is the evaluation of the brain. Now, what we have to do is just to move the probe from the heart, the lung, to the brain, and get all the information that I showed you about the perfusion, about the presence of midline sheath, about the presence of blood. And the same thing in cardiac arrest patients, who are those who have likely cerebral edema and die of cerebral edema. Even in this case, why not just adding brain ultrasonography to the initial and ICU evaluation of these patients here? Where are we now in terms of applying this in clinical practice? Not very well, I have to say. Last year we have done the guidelines for the basic ultrasound skill that a general intensivist should have. And for the brain, I have to say it was the worst part, because the panel people still think that these are advanced skills and that should not be basic. And the only recommendation that we obtained was the evaluation of the pulsatility index to rule out intracranial hypertension. So, in conclusion, the use of brain ultrasonography is a sort of stethoscope for the brain and can provide a number of information in severe traumatic brain injured patients about anatomy, bleeding, cerebral hemodynamics. The good thing is that it's bedside, repeatable, easily available, but we have to keep in mind also the methodological limitations and the fact that we have in our hand an ultrasound machine. Thank you very much.
Thank you, Chiara. There's time for questions from the audience. Yes, there's a question.
Hi, I don't know if you mentioned it in your talk. What kind of probe would you recommend to use for the transcranial Doppler?
So, if you have a non-decompressed patient, the cardiac probe is the one that generally has already the settings in the ultrasound machine, and it's the one that allows you to penetrate better in the temporal window. If you have a decompressed patient, you can use the abdominal probe. It's fantastic for that. And then for more sophisticated stuff like the evaluation of ONSD, you can use the linear probe. But most of the things that I showed you, cardiac probe.
Thank you. I have one. Okay, there's one more. Okay, Lori.
Chiara, great talk as usual. I am excited by where this is going for the field of neurocritical care. You did not comment much on temporal windows, and I think sometimes that can be a problem in getting good images. How do you handle some of those challenges when the window may be small, the skull thicker, other issues that you have to deal with?
So the good thing of going from the blind TCD to this methodology is that I found out that the number of patients that we defined with no temporal window, in reality they have a temporal window. So if you look at the literature in the blind TCD, you read an incidence of 10% of the patients who don't have the window. From our data here, it's about the 2%. In 2%, you really can't see it, but not more, because it's easier. I mean, the issue compared to the previous one is that you can't do it continuously because you have the probe. But there are some centers, some engineers who are working on that to make like helmets where you can fix the probe.
Thank you, Chiara.